Hi, this is Chapter 71, Care of the Patients with Gynecological Problems. The first specific problem we will talk about is endometriosis. This picture shows the female anatomy, and the most common places that you will see endometriosis is right here in the cul-de-sac, and then again right here on the ovaries. Remember that the endometrial lining normally grows right here in the uterus, so for it to be abnormally out here in the cul-de-sac and the ovaries is abnormal. So some concerns that we see with more common problems are pain, vaginal discharge, and of course bleeding abnormally outside of the period. Endometriosis is endometrial tissue, again, that implants outside of the uterus into outside of the uterine cavity, again, most commonly in the ovaries and the cul-de-sac, but it actually can be found in any of these places listed on this picture here. Pain is the most common symptom, and it peaks just before the menstrual flow. It kind of comes and goes like some of the breast disorders we were speaking of. You generally will see symptoms right before a woman will start her period. Treatment of endometriosis focuses on reducing the pain level, restoration of any sexual function that particular female may have. Dyspareunia is painful sexual intercourse, and a lot of women have this. They can have painful defecation, low back aches, and again, endometriosis plays a big part in infertility. Also, GI disturbances such as nausea and diarrhea are also common. Nurses need to take a detailed history, including the women's menstrual cycle, sexual history, any type of abnormal bleeding characteristics. Need to know, how many days she normally flows. Again, pain is your most common symptom of this particular disease processes. Endometriosis does progress slowly, and when patients are pregnant or at menopause, this does give the particular female some relief from the endometriosis. Although cancer of the endometrium is possible, having endometriosis does not put that person at any higher risk. Estrogen, tamoxifen, and hereditary conditions, also an excess amount of body fat, are more strongly linked to development of endometrial cancer. The cause is specifically unknown. The A condition called retrograde menstruation, which is when the menstrual blood kind of backs up through the fallopian tubes into the pelvic cavity, is thought to be a contributing cause, but there is no really way to know at this point. A pelvic examination will need to be performed by the healthcare provider. It may reveal some pelvic tenderness, maybe some nodules in the vaginal area, and limited movement of the uterus. These patients can have a lot of anxiety because they don't know what is going on. They don't know whether they have cancer. They don't know what the diagnosis is, and then they're extremely frustrated because of the pain that they are having. And then again, they also may be concerned with infertility if she is of childbearing age. Diagnostic tests that need to be ruled out are pelvic inflammatory disease. This can be caused by chlamydia or gonorrhea, which are sexually transmitted diseases. One thing to realize that one of the tests that is run to check for endometrial and ovarian cancer is a CA-125. Patients who have endometriosis can have a positive CA-125. So you must rule out each individual disease process before you can say a patient has cancer or a patient has endometriosis. Ultrasounds are used to determine whether any type of a mass can be endometriosis or whether it's a malignant tumor or something along those lines. We want to help these women, again, decrease their anxiety, educate really well on all of the tests that you plan to run on her, And then, prevention of self-concept disturbance, possibly related to infertility and the fact that they're possibly thinking, it's their fault that they can't have kids. Just a side note, some things that can be helped to treat endometriosis are oral contraceptives or birth control pills, Provera, um, injectable forms of progesterone such as Depo-Provera, which is a shot that's given every 3 months. These do help to keep the endometriosis in check and make it not so hurtful for the patient. You can also have heating pads, and then where there are some heat packs that you can put right up to the area that can provide temporary pain relief. Relaxation techniques like yoga may help decrease muscle tissue hypoxia and relieve the tissue that's injured by increasing the blood flow to the affected area. And then calcium and magnesium may also affect muscle cramping for some of those patients. Surgical management for endometriosis is doing a laparoscopy. The surgeon can go in there and actually remove the endometrial implants and adhesions and generally give that particular patient some time without pain. Most of the time the endometriosis will come back within a certain amount of time. Dysfunctional uterine bleeding is basically a disease of exclusion. It is made after ruling out all other causes or systemic conditions such as drug therapy or disease. Dysfunctional uterine bleeding is excessive and frequent bleeding, more than the every 21-day period cycle. It may begin at the beginning or end of a woman's reproductive years. When ovulation is becoming established, or when it generally is becoming irregular at menopause. Things to focus on: treatment options are to prevention of treatment or anemia. These are ladies who bleed an abnormal amount, and then controlling the bleeding via any type of a non-surgical or surgical method if necessary. Normally, your menstrual cycle is a series of timed hormonal events that are regulated by the hypothalamic, the pituitary, the ovarian, and uterine functions. Menses is the sloughing off of the endometrial lining inside the uterus, and this is an expected result. You want that lining to slough off. Dysfunctional uterine bleeding occurs when there is a hormonal imbalance, and which is generally when your ovaries fail to ovulate. The decrease in the hormones, the decrease in the progesterone production is needed to help that uterine lining mature and be able to slough off. So therefore it doesn't slough off, and then you have a lot of overgrowth, which allows the endometrial implants to happen. Without the progesterone, it causes the endometrium to grow into and past its hormonal support, and then the uterine lining is just sloughing off in other places. Again, you need to take a complete medical history, menstrual history, ask about illnesses, changes in weight or nutritional intake, look at signs of renal or hepatic disease, signs of hormonal dysfunction such as thyroid enlargement, evidence of any type of abdominal pain or masses, a complete blood count to determine whether the patient is anemic, and then things like TSH levels and other hormone levels, so that those can be evaluated as well. Treatment of dysfunctional uterine bleeding is hormone manipulation, generally hormone therapy. It just depends on the severity of bleeding and the age of the patient. Progestin, or a combination hormone therapy of estrogen and progesterone, may be given when the bleeding is very heavy. Contraceptives can be given if you just need to help stabilize the endometrial lining to where it's not overgrowing. And then long-acting progestins like Depo-Provera for women that are older than 35 or who smoke or at risk for DVTs. Again, all of these particular non-surgical managements can come with their own side effects, so you need to make sure that you have to watch those as well. Surgical management is called an endometrial ablation. It's basically a removal of the buildup of that uterine lining, and it stops the blood flow to the fibroids that are causing excess bleeding. It's a safe alternative for women who don't respond to the non-surgical management, and it is an invasive option, but it's relatively simple and easy and can be done in a physician's office. A hysterectomy is performed only after other treatments have failed. Toxic shock syndrome usually results from menstruation and tampon use. It can be fatal. These particular patients get a bacteria called Staphylococcus aureus. That is an infection, and it provides the growth for the Staphylococcus aureus. Exotoxins that are produced from this bacteria cross the vaginal mucus to the bloodstream, and then you get a really bad systemic blood infection. Again, this can be fatal. The signs and symptoms are fever, rash, myalgias, which is general aches and pains, sore throat, edema, and hypotension. Treatment focuses just on removal of the infection source, treatment with antibiotics, and again, not allowing that patient to use tampons. Pelvic organ prolapse, or a POP. Realize that your pelvic organs are held by what we call a sling of muscles and tendons. These sometimes become weak and they're no longer able to hold an organ in place. The most common type of pelvic organ prolapse is a uterine prolapse, and it can be caused by childbirth, especially people who have multiple children. Also caused by increased intra-abdominal pressure related to pregnancy, obesity, or physical exertion. You have a weakening of that pelvic support, and that's due to the increased estrogen. The next slide, which we will look at in a minute, will show the specific levels of uterine prolapse. Patients often report kind of a feeling of something falling out. Signs and symptoms can be dyspareunia, which again is painful intercourse, backaches, heaviness or pressure in the pelvis, bowel or bladder problems. The treatment options focus on the degree of the pelvic organ prolapse. Conservative treatment is usually preferred over surgical, and then things like Kegel exercises, intravascular estrogen therapy. So this slide shows grade 1 of the uterine prolapse here. Your uterus is bulging into the vaginal area, but the cervix doesn't protrude through the entrance to the vagina. A lot of physicians, when they are doing vaginal exams, can feel these uterine prolapses. And then you'll notice as time goes on, you're getting more and more of the uterine prolapse here. This one is going a little deeper in, and the cervix is protruding through the entrance to the vaginal area. And then with this one, the vagina is actually turned totally inside out. Cystocele are just the protrusion of the bladder through the vaginal wall. It can lead to stress urinary incontinence and consistent urinary tract infections. Rectocele, again, use the word recto, is a protrusion of the rectum through a weakened vaginal wall, so you have rectal prolapse. So in cystocele, you have urinary bladder prolapse, and in rectocele, you have rectal prolapse. Benign neoplasms are just like they sound. They're benign. They can be things like ovarian cyst, uterine leiomyoma, which is just your basic fibroids or myomas. Ovarian cysts can occur in a woman at any age, but they're very rare after menopause. Other cysts and tumors are not related to the menstrual cycle, but can arise from ovarian tissue. Your primary assessment involves doing a pelvic exam, an examination, and possibly doing an ultrasound. Also, testing that may be done are CAT scans, MRIs, and sometimes laparoscopic biopsy to rule out any form of cancer. A lot of ovarian cysts disappear over time. Some may cause discomfort, and then again, you can do a laparoscopy to remove a cyst or ovary if needed. Uterine leiomyomas are also called fibroids. They're benign, slow-growing, solid tumors of the uterine myometrium. They are classified according to their positions in the layers of the uterus, whether they are intramural, submucosal, or subserosal here. And I'm not going to spend a lot of time on this. Just realize that they are benign, solid growing tumors, and realize though that any time you have a tumor, it always has the presumption of possibly being malignant at some time. The cause is not known in regard to leiomyomas, but they do develop from an excessive growth of smooth muscle cells. Women with fibroids or leiomyomas usually do not have pain. The patient can seek medical attention because of heavy vaginal bleeding due to the fibroids. Symptoms such as the dyspareunia can significantly lower the patient's quality of life, so these particular patients will be seeking medical care. I'll just touch briefly on hysterectomies. Leiomyomas or fibroids are the most common reason for hysterectomies. They can be performed abdominally, vaginally, or with a laparoscopic or robotic assisted. It just is based on the patient's reason for the hysterectomy and whether the hysterectomy can be performed vaginally, or the patient needs to have a full abdominal incision. Sometimes patients who are obese will need to have a total abdominal hysterectomy, and also if the fibroid or leiomyoma is pretty large, then they'll also need to have an abdominal hysterectomy. Again, can be indicated for multiple gynecological problems, endometriosis, fibroids. Postoperative care focuses on the management of the vaginal bleeding, incisional intactness, making sure the urinary output is okay, and then of course pain management. Bartholin cyst is a common disorder of the vulva area. It results when the ducts that are in the Bartholin area get obstructed. The fluid fills up, the glands secrete. The glands continue to secrete even though the gland is obstructed, and then the fluid fills the obstructed duct. The main causes of the obstruction can be infections, thickened mucus near the ductal opening, or trauma such as lacerations. These patients may be asymptomatic, and they can be, Bartholin cyst can be removed by just doing a simple incision and drainage. A physician will go in there and open up the cyst and go ahead and drain it out. Realize that these cysts, because of where they are located, Most of them are located in the perianal area, can be very painful. Patients can have painful intercourse. You want to assess for swelling in that area. A large Swiss cyst can cause a lot of local pain and may cause difficulty walking or sitting. The cyst can appear brown or bloody depending upon its contents. Vaginal discharge may be present, or if there is an abscess, there can be an infection, and sometimes that can be caused by a sexually transmitted disease. If the disease is draining, it's always good to send a fluid sample to the lab to make sure the patient doesn't have an STD present or any type of other organism. If the woman is older than 40 years, then a biopsy would need to be done of the cyst to indicate and identify possible cancer. That is the end of the lecture. Thank you and have a good day.